with the doc. I don't know how you guys planned it, but another gorgeous day. Who would have thought October would be like this? A record-smashing day, possibly. But it's great to have everybody here. For those that are new, first time here, welcome as well. Hope you have your shirts. And by the way, reminder for everybody, there is free parking in the garage during the event. When you pull in, you get your ticket, and then the gate stays open for about a half an hour after we all finish. So there is free parking, so feel free to come into the garage. That way it'll be shaded, as opposed to darting away from far away at one of the parking lots over there too. So welcome back. Hope you all been very active in the last couple weeks. Had a little 1 week of, I guess, cloudy weather, but it's bounced back again for maybe the final week of the summer weather. And a special treat today, we have Dr. Rao, one of our vascular surgeons, who is new to our facility. And you'll have a chance to ask him some questions. He's going to talk about peripheral arterial disease, which is, when you think about it, it's atherosclerosis, if you will, of the vessels, for instance, outside the heart. So he'll bring his treasures and talents to our little talk today, and also give you an idea of what he does at the hospital. Dr. Rao?
Okay, well, welcome everybody, and thanks for partaking and letting me speak here a little bit about peripheral arterial disease. I am new here. I just came from Brooklyn. Well, I was in Philadelphia prior. I had been at Jefferson before, so I sort of know the area. But I got to say, this is a far cry from Brooklyn, where I was the last 4 or 5 years. We never got to walk like this or spend a day. That's why you saw me snapping pictures. But I just wanted to touch. We do as a vascular surgeon, there's a lot of different things we do, and one of the primary things or diseases that we treat, as Dr. Comezzo was mentioning, is peripheral arterial disease. You might have heard of it in the past as peripheral vascular disease, or PVD, but now PAD, and you may hear of it on TV and commercials for different medications, etc. But it's becoming more and more of a known problem. It's existed for years, but it's becoming sort of into the limelight more often. And what is peripheral arterial disease? Well, simply put, peripheral arterial disease means blocked arteries in the periphery, which means anywhere stemming away from the heart, any of the arteries. But when we specifically talk about peripheral arterial disease, while it can involve any of the arteries, the ones that we most commonly deal with and focus on are those of the leg arteries. They can get blocked up and lead to symptoms just like blocked heart arteries. That leads to things like heart attacks or angina, you might have heard of, things like that. Well, the same type of things can happen to in the legs. So the question is, first of all, what happens and who's at risk for it? Well, what happens really is sort of hardening of the arteries. And it's the same process that can occur in the arteries to the heart, in the arteries to the brain, and everywhere in the body. And what occurs is the deposition of plaques. You might have heard of plaques or atherosclerosis. And that means that basically there's inside the wall of the artery, there's been some this deposit of cholesterol and fatty stuff and all these other things that form a hard plaque. Eventually that plaque can plug up the lumen. It grows into the lumen or channel of the blood vessel and blocks it up. As a result, it can limit the blood flow and cause certain problems. So who's at risk for things like this? Well, it's really the same sort of risk factors as heart disease. So people who have heart disease are at risk. People who age, as we all age, we can develop some degree of hardening of the arteries. Genetics plays a component, so people who have family histories of heart disease or hardening of the arteries tend to be more prone to it. And then things like diabetes, uncontrolled blood pressure, uncontrolled cholesterol are felt to be associated risk factors for the progression. And the #1 reversible risk factor is smoking. And it's very common in our patients to have been long-time smokers. And smoking cessation or stopping of smoking is great in terms of preventing progression, but unfortunately the damage that's been done over the years of smoking can't be necessarily reversed. So once we see a patient who's been a long-time smoker, we try and get them to stop to prevent any progression, but we still may need to treat some of the problems because of the buildup of plaque over the years. So what sort of symptoms? So that's kind of a nutshell of what peripheral arterial disease is and why it occurs and who it occurs in. But what happens? What are we treating here? Well, typically in the legs, there's two different categories of blocked arteries or peripheral arterial disease in terms of symptoms. And number one is patients develop something called claudication, and I'm going to talk about what that is in a second. And the number two is what we call limb-threatening blockages. And that means that the blockages are so bad that they can threaten the viability of a leg. And that's a really serious problem. Let's go back here for a second. So what's claudication? Claudication means pain when you walk, basically. And the way I tell patients, it's sort of to think of it. It's analogous to construction on a highway. So your blood vessels are like a big highway. It's like 95. So if you run into a construction zone on Route 95, it narrows it from 3 lanes to 1 lane in a construction zone, okay? Well, if you're driving at 2 in the morning and you're going at 60 miles an hour, when you hit that construction zone, you're not going to slow up too much. You're still going to go at 50 or 60 miles an hour. But take into account 8 a.m. rush hour now. 8 a.m. rush hour, you go from 3 lanes to 1 lane, and now you're going to cause significant delays. Well, that's sort of what's happening in the legs. It's sort of a rough analogy in that blood at 2 a.m., which is when you're at rest, when you're not moving, you're able to get enough blood to meet the demands of the muscles and tissues in the leg. However, at rush hour, which is like when you're walking, your muscles need more blood, your nerves need more blood, and now that narrowing or blockage becomes really apparent. And so that results in causing pain. It's actually pain due to the nerves not getting enough blood rather than the muscles, but that causes pain. And so that's sort of the analogy of what's happening in the leg. Now, eventually the blockages can get so bad that they can result in what we call limb-threatening problems, in which case if we don't do anything soon, there's a risk of things like gangrene and losing limbs. And so it's a very serious problem. It can be. The nice thing is the majority of people with what we call claudication or early peripheral arterial disease don't progress, the majority of people. So if you control your risk factors, you can avoid sort of progression to the worsened stage. And that's what's important to know as a community. You can help limit your overall risk factors. So we can't control genetics. We can't control aging, but what we can control are the other risk factors. So keeping your blood pressure under control, keeping your blood sugar under control, and keeping and stopping smoking cessation are key elements to help keep things at bay. Similarly, the medicines that have evolved for the heart are very effective in the legs as well. A daily aspirin, statin medications, these things can help reduce the progression of plaque, as well as prevent clogging up entirely of the blood vessel. So, and finally, exercise is important. But what type of exercise specifically? Walking is actually the best form of exercise. And the reason is what walking does is if you do have narrowings or blockages in the arteries, walking, exercise, and medicines alone will never bust open those blockages. Unfortunately, they're hard blockages and they're not going to magically open up with any medicine or walking. But what walking can do for you is, if we go back to the analogy of Route 95, if you're blocked up on Route 95, well, what do you do when you hit a traffic zone? You get off and you take a detour or exit to go around the blockage. Well, that's what walking does. It exercises those detour pathways. So your body forms detour blood vessels around the main blocked vessel, and by walking, it exercises those, helps grow more of those, and helps grow them larger so that more blood can flow down the leg to meet the demands. So that's where sort of you can help yourself, and walking becomes apparent, and hopefully we'll all do some walking today. And that's sort of my spiel on peripheral arterial disease, and hope that was helpful to everybody, and I look forward to the walk.
I have a question.
Yes, sir.
So we know Dr. Rao does a lot of treatments at the hospital as well as the things he just discussed. Do you consider yourself more of a surgeon or a plumber overall in terms of doing stents or surgery or both?
That's actually a fantastic question, because I didn't talk about a lot of the invasive treatments that we offer, or as a vascular surgeon or a vascular specialist. And as a vascular surgeon nowadays, it's really fun for us because we don't consider ourselves, in the end I say I'm a vascular surgeon. However, we're not solely surgeons, we're not solely interventionalists, we're not solely internists, we're a little of everything. medical management is important. So controlling risk factors like diabetes, blood pressure, cholesterol is important. Talking to our cardiology colleagues and associates and working out a plan of conservative treatment. Talking to patients about exercise. These are all, and seeing them regularly and making sure that everything is doing okay on a regular basis. It's a little different than the typical surgeon. So in that sense, we get to be internists. And then what do we offer invasively? Well, there certainly open surgical surgery, techniques are involved, so major open surgeries sometimes we need to do, but we also do minimally invasive things like balloons and stents. And a lot of the problems now with vascular diseases are treated minimally invasively. Unfortunately, we can't treat them all with it, and it all depends on the anatomy, what's been done before, and the patient themselves. Certain patients lend themselves better to open surgical repairs, certain lend themselves better to minimally invasive repair. So we like to think that we are sort of the overall plumbers, and we can offer you the best repair, whether it be roto-rootering or sewing in new pipes. Whatever the technique, it's all just plumbing of the blood vessels. You know, I think that's what a lot of doctors are nowadays, are plumbers. GI doctors are plumbers of the intestinal tract. We're plumbers of the blood vessels. So.
One more question for you.
Yes.
I had an IVC filter put in me for blood clots, and the surgeon tried to remove it, and he couldn't remove it. Is there something I can do to make it easier for it to be removed?
So his question is about what's called vena cava filters, and that's a little bit different than what I'm talking about today. That has to do with the venous side. So what I was talking about are blocked arteries, which bring blood from the heart, under the pulsation of the heart, down to the legs, and blockages in the arteries and the problems that ensue as a result. He's talking about the veins, which bring blood back towards the heart, can develop blood clots. That's a completely different process. It's called deep venous thrombosis, or DVT, and oftentimes a little filter or umbrella needs to be placed into what's called the vena cava, or the large vein, to trap any major blood clots that may go to the other side of the heart. That's slightly different, and there's nothing you can do to ease generally to ease the retrieval of those.
No exercise would do any good?
No exercise would do any good for those, unfortunately. It's anatomical positioning. It's related to the anatomy of how it's positioned and how long it's been in, really, as to the ease of retrieval. But that's a little bit different than the arterial side we're talking about here.